Chapter 6, Computers and Health Information Management. Health informatics is the scientific discipline that is concerned with the cognitive, information processing, and communication tasks of healthcare practice, education, and research, including the information science and technology to support these tasks. HIM systems include release of information and disclosure management systems, encoder and grouper system, cancer and other registry systems, chart locator system, birth certificate system, chart deficiency system, transcription, healthcare quality indicator system, dictation, computer assisted coding, and clinical documentation improvement. The release of information system is designed to manage the processing of requests for protected health information, PHI, received and processed by the HIM department. A disclosure management system tracks the disclosures made throughout the healthcare facility for reporting purposes. Disclosure is the release, transfer, provision of, access to, or divulging in any manner of information outside the healthcare facility holding that information. This tracking is required by the Health Insurance Portability and Accountability Act, or HIPAA. The disclosure management system may be part of the ROI system, or it may be a separate information system used by HIM and non-HIM departments. The ROI system is a valuable tool for ROI staff. Once the requests for copies of records are entered into the ROI system, the data can be used for many different purposes to support the workflow. The ROI staff can use the system to check on the status of requests. The status of a request must be updated and kept current by ROI staff at all times. The status can include details about issues encountered, a need for review by risk management, or a need for health record or a microfilm to be pulled, or other action required. Page 87 of your textbook has a workflow diagram of a typical ROI process. ROI data elements include patient name, health record number, patient type, date request received, type of requester, name of requester, name of contact at requester, address, type of request, whether it's insurance, patient, attorney, or patient care rep. Other elements include who it was assigned to, the action taken, charges, amount paid, amount due, and any comments. ROI reports can include requests that have not been processed, requests that have been processed, turnaround time, revenue collected, accounts receivable, productivity by individual staff members, overall productivity, list of frequent requesters, and multiple customized letters. Customized letters are critical to the ROI system. Customized letters and forms may be used to communicate with the requester for many purposes, including to notify the requester that the healthcare facility does not have the record, remind requesters that they have an outstanding balance for their copies, provide a cover letter for health records being sent, request that an authorized is needed, notify the requester that there would be a delay, notify requester that the records will be released as soon as the healthcare facility has received prepayment, generate invoice for the copies of the health record, and generate reminder invoices when payment is not received in a timely manner. HIM department managers monitor the efficiency of ROI staff through a multitude of management reports. These reports provide information on various functions, including turnaround times, productivity, backlogs, revenue, and accounts receivable. The encoder is specialty software used by coders to select the appropriate code for the diagnoses and procedures supported by the health record. There are two types of encoders. There is a rules-based encoder which requires the user to type in the name or portion of the name of the diagnosis or procedure. This entry into the encoder generates a list of suggestions from which the coder selects. The automated codebook encoder lists diagnoses. The grouper is a computer program that uses specific data elements to assign the diagnostic and procedural codes entered into the encoder into the appropriate Medicare severity diagnosis related group, also called the MSDRG. The grouper uses the appropriate grouping software for the insurer assigned to the patient. The most common groupers are the MSDRG grouper and Ambulatory Payment Classification, or APC grouper. Other insurers, including some Medicaid programs, have developed their own groupers for use in determining payment to the healthcare facility. The grouper software is connected to the billing system, so it is important that the HIM staff have a strong relationship with the billing and finance personnel. Coding quality and MSDRG assignment are not ensured using an encoder because the code selected is only as good as the data entered into the information system. One of the biggest advantages in the use of an encoder or grouper is prompts. For example, if a higher paying MSDRG can be assigned with the addition of a specific diagnosis, specific procedure, complication and comorbidity, or major complication and comorbidity, then the computer will ask the coder if any of them are present. The grouper also allows the coder to resequence the principal diagnosis when more than one diagnosis meets the definition of the principal diagnosis. The encoder can assign the ICD-10 CM code, the ICD-10 PCS, the CPT, and HCPCS codes required on the patient claim. These assigned codes must be validated through the Medicare Code Editor, the National Correct Coding Initiative, and other edits. These edits will look for invalid codes, illogical codes, nonspecific codes, and other possible errors. Some common data elements in an encoder in group or grouper are admitting diagnosis, principal diagnosis, secondary diagnosis, principal procedure, secondary procedure, age of patient or date of birth, discharge disposition, gender, patient name, health record number, and the account number. The encoder and grouper are usually linked to the hospital's financial information system so that the codes can be automatically transferred to that information system for billing. Without this link, the coder would have to re-enter codes into the financial information system. This double entry leaves room for data entry errors, which would in turn cause problems with billing and reimbursement. The encoder or grouper does not contribute heavily to reporting. Rather, the encoder is more about assigning codes and MSDRGs using edits to assist the coder in proper assignment of codes and other information transferred to the hospital financial system. However, if needed, the information system may be used to generate a report listing all of the codes and respective MSDRGs or APCs assigned for further analysis. There are many types of registries currently found in healthcare. A registry is a collection of care information related to a specific disease, condition, or procedure that makes health record information available for analysis and comparison. These registries track conditions such as cancer, diabetes, trauma, and transplants. All registries are designed to record data on patients who meet criteria for inclusion in the registry. These registries would generally require demographic information, reporting, treatment, description of condition, and frequently long-term patient tracking. Commonly found data elements across registries include patient name, health record number, date of service, physician, date of birth, date of diagnosis. The Cancer Registry Information System tracks information about the patient's cancer from the time of diagnosis to the patient's death. Some of the more common data elements unique to the Cancer Registry include site of cancer, type of cancer, treatment received, date of last contact, the TNM stage, which stands for tumor node metastasis, number of lymph nodes involved, behavior type, date of death, grade of neoplasm, size of mass, physician name, and the accession number. The Cancer Registry can electronically submit a file containing the data required for state cancer reporting. Once data on all identified cancer cases for a designated time period are verified by the cancer registrar or designee of the healthcare facility, a programmed report is automatically generated and transmitted to the respective statewide cancer registry, normally housed in the state's Department of Health. Cancer registry software can also assist the registrar in the patient follow-up process. The information system can provide management reports such as productivity as well as reports on the content of the registry. Common reports include life expectancy, follow-up rate, list of patients due for follow-up, patients lost to follow-up, and follow-up letters to patients and physicians. The Trauma Registry software tracks patients with traumatic injuries from initial trauma treatment to death. Common data elements include site of injury, type of injury, how the injury occurred, date of injury, time of injury, work-related injury, the ICD-10-CM and ICD-10-PCS codes, safety equipment, registry number, autopsy performed, and emergency department arrival time. Trauma registry software packages generally include report writers for ad hoc reporting. Common reports for trauma registry would be similar to those of the cancer registry, such as outcomes, follow-up rates, and best practices for patient care. The information system would provide statistics on cause of injuries, types of injuries, and other descriptive statistics. The chart locator system, also called chart tracking system, is designed to identify the current location of the paper health record. This tracking is important because paper records are moved from place to place for patient care, quality reviews, coding, and many other purposes. The Joint Commission regulations require health records to be readily accessible for patient care. Data in the chart locator system identifies where the record is currently physically located, how long it has been in that location, when the record is due for return to the HIM department, when a record is overdue to be returned, and who checked out the health record. Common data elements in the chart locator system are patient name, health record number, volume, location to which the record is checked out, date record checked out, date record returned, who checked out or checked in the record. Management uses the chart locator reporting for multiple purposes, including identification of most user requests of health records, productivity tracking, identification of trends in the volume of health record retrievals, and identification of areas of the healthcare facility for which records are not returned in a timely fashion. Documentation requirements are based on the accreditation regulations, state licensure regulations, federal requirements, and other standards or regulations that the healthcare facility is subject to. Specific documentations requirements mandate when reports such as the history and physical exam should be dictated or written. It also mandates the content of the various reports analyzed and the deadline by which the entire health record should be complete. This deadline would also include the presence of all required and the authentication of these documents. Documentation omission is recorded and tracked in the chart deficiency system. Deficiencies can be in paper, imaged, or electronic records, depending on the information system used. With imaged or electronic records, the physician can complete the deficiency from his or her office, home, or other location. With paper records, the physician must come to the designated area in the healthcare facility. The chart deficiency system should be linked to the hospital information system so that patient name, discharge date, and other demographic information are maintained and automatically populated. The chart deficiency system is utilized by both staff and management. Common data elements in this system are patient name, health record number, discharge date, the physician needing to complete the deficiency, the type of document with deficiency, the type of deficiency, date of surgery, comments, and the date the physician last worked on the record. When a patient is just discharged from the hospital, the health record is automatically reviewed for deficiencies. In an electronic environment, a work queue would route the deficiencies automatically to the assigned physician. The physician could then automatically complete all needed deficiencies from home, the office, or anywhere in the hospital. There may also be a link between the dictation system and the chart deficiency system to automatically update the status when a report has been dictated or described. This link would also help staff locate paper records for completion. Data quality is critical to the chart deficiency system. Records inappropriately entered into the system can also have a negative impact on the accreditation or state federal regulatory statistics, as well as customer service. To improve data quality, routine audits of the records should be conducted to ensure that records are still incomplete and available to the physician. Management uses the chart deficiency system to age the deficiencies for the Joint Commission tracking. The chart deficiency system can generate a report listing all physicians suspended for delinquent health records, which is an incomplete record not finished or made complete within the time frame determined by the medical staff of the facility. It can be used to track when physicians are suspended. This is for use in medical staff credentialing, and monitor the volume of deficiencies by physician and service. The chart deficiency system also has customizable letters. For years, birth certificates were typed on a typewriter and manually sent to the local health department. Now, after the HIM staff interviews the mother or other parents or guardians and reviews the health record, the birth certificate data are entered into a state-approved birth certificate information system. Birth certificate software will capture the minimum data set established by the National Center for Health Statistics. Functionality common in birth certificate information systems include collecting data mandated by NCHS, reporting standard information such as the name of the healthcare facility automatically, allows users to choose from obstetrical physicians table, capturing demographic information from hospital information systems to improve efficiency, preventing omissions of required data before birth certificate is sent to the state, using mandatory fields and edit checks. Also submits birth certificate data automatically to the state or local health department, submits parents' request for social security number, prints out data captured for parents to proofread, creates a birth log, uses drop-down boxes to improve data consistency, uses edits to improve data quality, and it allows parents to order a copy of the birth certificate. The birth certificate may also generate statistical reports such as cesarean section rate or trending birth rates. The key reporting capability, however, is the ability to report the births to the state in the approved format. The state may use birth certificate data reported via the birth certificate system to feed other databases, such as the immunization registry, to enhance tracking of childhood immunizations. The dictation system is used by physicians to dictate various medical reports such as history and physical exams, discharge summaries, radiology reports, autopsy reports, catheterization reports, and other designated reports into the dictation system. Dictating is the process of recording a physician's voice as he or she verbally describes a scenario, problem note, or some other type of report that is recorded electronically. The transcriptionist then types the actual report using the transcription system. Transcription is the process of deciphering the provider's recorded dictation and typing the medical document. The transcription system should be interfaced with the hospital information system so that the patient name, health record, and date of service are already populated within the information system. Voice and speech recognition technology is becoming more prevalent in EHR systems. Voice and speech recognition software translates the spoken word from the dictation to the written word or text in an electronic document. A document editor would use the appropriate documentation or transcription software to correct any errors that the system made in the translation of voice to text. However, the physician or provider is ultimately responsible for the content of the transcribed report and must make corrections or changes accordingly, if necessary. The transcriptionists utilize the dictation system to listen to the dictation for transcription. The dictation system will route priority reports to the transcriptionist ahead of other dictated reports in the work queue. HIM managers use the dictation system to route dictated reports to various transcriptionists. The key reporting focus for the dictation system is on workload. The system is able to track the volume of work dictated and how much is remaining to be transcribed. This information can be used to determine transcription staffing levels, overtime workload justifications, and trends and patterns in dictation usage. The transcription system typically has user-defined templates for each report type. The template prevents the transcriptionist from having to type headings, such as history of present illness or review of systems, every time a history and physical examination is dictated. The information system typically uses expanders, which may also be called macros. An expander allows transcriptionists to type an acronym such as CHF, and the full phrase congestive heart failure will automatically be spelled out. This saves keystrokes and time. The expanders can typically be controlled by the healthcare facility. The transcription software products in use today are designed to work seamlessly with dictation systems and voice recognition systems to promote efficiency in the entire process. These products are also designed for transcriptionists to work from home as appropriate. The transcription system is used by management for various purposes. One purpose is to track productivity, which is critical because transcriptionists usually are paid based on it. Another purpose would be for incentive pay. Many information systems can calculate incentive pay automatically based on criteria established by the healthcare facility. Incentive pay is a system of bonuses and rewards based on employee productivity. Management may use the reports to monitor overall volume by report type to help identify trends and needs. The Healthcare Quality Indicator System is an abstracting system that records information about the patient, the care provided to the patient, and the healthcare practitioners involved in the care delivered. Abstracting is the process of extracting information from a document or data elements from a database to create a brief summary of a patient's illness, treatment, and outcome, and entering the summary into an automated system. A quality indicator is a standard by which care may be measured to identify a level of performance for that standard. Users in the HIM department may be the coders or a separate group of employees with the necessary skills and qualifications to read, understand, and abstract information from the healthcare record into the quality indicator system. Abstracting and reporting are two critical aspects of the quality indicator system. Because the data from this information system will be used in performance improvement, reporting is a key part of this information system. Reports will include statistics and graphs to facilitate the identification of trends. Reports may include monitoring healthcare facility infection rate, number of deaths by physician, blood incompatibility, surgical errors, maternal deaths, and outcomes. The computer-assisted coding, or CAC system, analyzes the clinical data found in an electronic health record. CAC is the process of extracting and translating dictated and then transcribed free text data, or dictated and then computer-generated discrete data, into ICD-10-CM, ICD-10-PCS, CPT codes, and E&M codes for billing and coding purposes. It utilizes natural language processing, NLP, to analyze clinical data to identify diagnoses and procedures and to assign the appropriate codes into the CAC system. NLP is a technology that converts human language, whether it be structured or unstructured, into data that can be translated, then manipulated by information systems. Despite all this, the coder must still review the health record documentation to confirm the accuracy of the code. The CAC suggests codes to be assigned. The coder reviews the codes and then either accepts or rejects them. The CAC system generates productivity reports. It can also generate reports on the number of health records where the codes were changed from what the software originally recommended. These reports are important to evaluate the quality, accuracy, and completeness of the codes generated by the CAC system. This evaluation or review can be combined with the financial information to determine what impact this may be having on reimbursement claims and revenue cycle functions. The Clinical Documentation Improvement, or CDI system, assists in identifying ways to improve clinical documentation in the health record. CDI is the process a healthcare entity undertakes that will improve clinical specificity and documentation that will allow coders to assign more concise disease and procedural classification codes. When documentation improves, the code assignment will be improved because codes can be more specific. Another benefit of improved clinical documentation is more accurate reimbursement.